Thank you all so much for being here. This is such a pleasure to get a chance to spend this afternoon with you. And before we dive in, let me just ask, is anyone's brain completely full? It's towards the end of the first full day of the festival. You're up to here? Okay, so our goal during this is to fill up your brain. So whatever space you have left over, we want to fill up. And luckily, you are here for a treat because we're going to talk about the future of healthcare, about where it's going with three folks from Mount Sinai who know more probably about healthcare than anyone I've ever interacted with. Let me start by introducing them. Dr. Kenneth Davis is the CEO of Mount Sinai. For those of you who aren't from New York, Mount Sinai is huge. It has 8 hospitals, 400 ambulatory sites. Dr. Davis's background is as a clinician researcher. He's done some of the groundbreaking research on understanding Alzheimer's and how to think about treating it. Dr. Sidney Hankerson directs the mental health equity research at the Institute for Health Equity Research and is a psychiatrist by training and has spent a lot of his time thinking about mental health, particularly in underserved communities. And then Dr. Robert Fields is a family doc who also serves as the chief people health officer for Mount Sinai. Did I get it right?
Population health.
Population health officer, and thinks a lot about how we not only provide care, but how we pay for care. And so what we're going to talk about today is we're going to try and diagnose what the problems are in this system, both for patients and for people who have to pay for those patients. And how do we improve those? What are the solutions? And so let me start with you, Dr. Davis. You're a grandfather. How many grandkids do you have?
5.
5 grandkids. What are you worried when they become adults? What are you worried they might inherit that we want to try and prevent, given a decade, 2 decades of work we can do?
Well, that's an interesting question. And usually, and these guys will tell you this, I'm a characterological pessimist. So it should be easy for me to answer that question. But characterological pessimism is a good thing to do when you have to run a big healthcare system where your margins are at best 0.5%. So to turn your question around, what I'd like to think about is not what I worry about, but what the world might be for them. And part of the answer is, I hope that the kinds of work that's going on at Mount Sinai and other places will cure cancer. The work that we're doing in the genetics of aging will make my grandchildren look back and say something like, can you believe it? They all died at about age 80. And we're going to live to like 150. I mean, I can't get over it. Because we are on the precipice of a revolution in biology that is equivalent to the revolution in physics that happened about 100 years ago. And 100 years ago, they would have never sat around and said, you know, there'll be nuclear energy. And you think about all the things that happened because of the revolution of physics. Well, the revolution of biology could do that. So when I think about my grandchildren, instead of my characterological pessimism, I think it's going to be great. It's potentially going to be a really different world, and I'm glad that at least we had the basis to make that happen in our generation.
And do you think we're going to get there?
I think we will. I mean, you know, obviously there are decisions that have to be made at a governmental level about how well they fund science.
Yeah.
And we hope that it maintains or exceeds the percentage of GDP that it is now. But yeah, I hope it can.
Yeah, I think so too. I think, Dr. Hankerson, let me ask you, you've spent your career thinking about how to deliver mental health services to folks who don't necessarily come through the front door. We can't count on them to do that. Tell me a little bit, how did you get there? Like, what was your path to psychiatry and to activism?
Sure, thank you for that question. So my path to really trying to serve underserved communities started in 2003 with a groundbreaking paper that showed that across this country, regardless of a person's racial or ethnic background, and regardless of their religious affiliation, when people are experiencing a depressive episode, they first likely get care from their pastor, so from their faith leader, more so than they get care from psychiatrists or from primary care docs. And so our clergy are really frontline mental health professionals. And so that got me thinking that perhaps we could think about ways to translate the tremendous healthcare that is provided in healthcare settings into trusted community settings. And how could we create bridges between trusted community-based organizations and the wonderful science that is done at academic medical centers like Mount Sinai, and really bridge the bridge and connect people to care timely ways, in culturally relevant ways, and in quality ways.
Yeah. And I want to draw these together. Let me ask first, Dr. Fields, you're a family physician, you're a clinician, and if I remember correctly, you actually opened your own practice in North Carolina that was not the most successful chapter of your life. From a financial perspective, tell me a little bit, I mean, you've been on the front lines of trying to figure out how to provide care.
Yeah, it was the most expensive MBA you could ever imagine. I opened a practice straight out of residency with a good friend of mine with this idea that I would be doing that for the rest of my life, small community practice in the mountains of North Carolina. Didn't get private equity or venture money, which is now the way that people open practices these days. Went to a bank and mortgaged my house, did it the old-fashioned way, and we provided care for the only Spanish-speaking primary care practice in the entire 20-county region was the county health department. And so we opened a practice that was designed to be bilingual, front desk staff, very culturally competent care. And it was wonderful clinically. It was really successful in lots of ways in terms of what I learned. And clinically, it was incredibly gratifying to serve the community. It was pretty old school family medicine. I was still rounding in the newborn nursery, saw babies, I saw 104-year-olds, saw the whole gamut. And it was wonderful. We were early in 2005-06 doing patient portals and e-prescribing, like really early. For those of you that are tech savvy, our tiny practice of 2 family docs had 4 huge IBM servers in the back, because this is pre-cloud computing. But the downside of that from a financial perspective, which started to open my eyes a bit to what's broken in the financing of healthcare, is that along with that came a huge chunk of Medicaid patients, right? Many of the patients I was seeing were served by state Medicaid. My partner really loved geriatrics. He had a very heavy Medicare influx as part of his panel, and that ultimately was not sustainable. We grew tremendously. We grew to 5 physicians over the next several years, but ultimately we're at risk of bankruptcy, personal bankruptcy, right? Because it was our money. Before the hospital acquired us. And it just made me realize that people that needed care the most, it was not sustainable to provide care to the people that needed the most in the standard model. It was just fundamentally broken in primary care. And not knowing what population health was, I'm not sure the phrase existed at the time, kind of led me to a path that landed here about changing how incentives really have driven a certain type of outcome in the US that we're trying to address and fix.
So this, and let me say, I'd love for this to be a conversation. If you have a question, a comment, a thought, just raise your hand. We've got some microphones to run around to you. Really make it a participatory. But if I was to listen to the 3 of you, I'd think to myself, oh, healthcare's taken care of. We have these 3 really smart people. They seem so dedicated. They put their own house on the line. They have grandkids. So size up the problem for me. What is the thing that's stopping all the work that you guys want to do from happening?
We're grossly underfunded. Mount Sinai Health System is about 2/3 Medicare and Medicaid. And when you lose 40 cents on the dollar in every Medicaid patient, 15 cents on the dollar in every Medicare patient, your commercial insurance isn't going to make that up. So we scrounge for a break even every year. And to provide the high quality care we do and still have that financial pressure is very, very difficult. We're supported by a great deal of philanthropy that helps. And we're always looking for new ways to generate revenue, which we've been fairly successful at doing. But this is an equation that doesn't equate. Case study, the last couple months. Staffing shortages and inflation in the supply chain. There's no way that we can turn around and say to the Medicaid people and the Medicare people, the feds and the state government, you got to increase our rates. It's not going to happen. We're not going to renegotiate our commercial contracts. It's not going to happen. So we sit here now pondering the imponderable, which is how do you make this equation work when it was already bad? Now it looks impossible.
But explain to me why this is true, because I keep on hearing every article I read, the U.S. spends more of its GDP on healthcare. I think you just mentioned this. If that is true, if we're spending so much money, why isn't it trickling down?
Well, Rob can talk about this even better than I can, but Fee-for-service medicine is just not the most efficient way to practice. And that's the system we're in. And we can't rely on what we cross-subsidize from the commercial insurance to make up for the underpayment, the gross underpayment from the federal and state providers.
So Dr. Fitz, let me ask you, because you introduced me to this idea called value-based purchasing and how we compare to other countries when we think about what we're spending,
right,
and that maybe we're making the wrong calculations. Tell me what that is. Like, what is the right way to be thinking about spending on healthcare?
So I often correlate it with healthcare is like a factory. Consider it like a widget factory. We just make really complex widgets, right, in terms of healthcare spending. In other words, we provide services. We deliver a product. The system is designed to deliver that product really well. We can, in terms of technology and advancements, we can deliver those things with unbelievable precision and scale. But we are incentivized to do exactly that, is to produce widgets, to provide services. We're not paid to provide wellness. We're not paid to provide health. We're there to provide services. And we get paid for those services in a differential sort of way, as Ken's describing. We get paid a lot more for commercial, a lot less for Medicaid. The dirty little secret of healthcare in the United States is that cost shifting occurs, that commercial contributions to healthcare spending subsidize the care of our government-insured patients. And that is not sustainable. And as Ken has alluded to, we're hitting a ceiling on that now, because ultimately, many of you are employers. You don't want to pay double-digit increases in your premiums to subsidize the care of Medicaid patients, right? We don't as consumers, if we buy our own plan. We don't want to see double-digit increases in our own premiums. Nevertheless, for decades, that's the way U.S. healthcare has been financed. And we're running into that ceiling. So part of what we try to do at Sinai, among other systems in the country, but we're certainly leaders in our region, is really changing that model. Instead of just getting paid for widgets, really getting paid for a whole budget, whole person budget. If we can come up with a fair characterization of what it should cost to take care of that patient and give us the freedom to invest those dollars in the way we think has the biggest impact, you start to change your mindset in terms of what actually drives value. For instance, providing food for somebody that has heart failure and is discharged from the hospital and providing medically tailored meals is probably much greater benefit than 1,000 other things we would normally do that get reimbursed today. But we're not incentivized to do that. But in these models, we are. And you can extrapolate from that a million other things that we could be doing in terms of how we invest up in the upstream drivers or social determinants of care. What that does for us is that if we get great outcomes, we reduce the total cost, our revenues, our margin now comes from that savings rather than just providing services. And so it really helps us think about the way we provide care. I have a fundamental belief that doing the right thing by patients is a less expensive way of taking care of them. And that's essentially the mantra that we're trying to fulfill at Mount Sinai.
Dr. Hankerson, you mentioned that the clergy is often the front line, and it occurs to me that in addition to talking about the whole person, and when talking about ways to offset the fact that Medicare and Medicaid aren't paying, that relying on community organizations like clergy could be a part of the solution. I know that you've worked with NYCHA, the New York Commission on Housing and Affordability, I think that's what it stands for, but public housing in New York, which there's a huge amount of, to try and get some of those services into people's lives before they're having a crisis. Did that work? What challenges did you find in making it happen?
Well, I haven't worked directly with NYCHA, but I do want to reiterate Rob's point about social determinants of health. We know that where you live, play, work, and age impacts your health more so than the health care that you receive in the hospital. And so we know that your zip code is a greater predictor of your health than your genetic code. And so it's critical to think of ways to address these social factors that contribute to people's health, whether it's housing insecurity, whether it's access to food. And so I think that the relationship between policy and healthcare is critical. And I'd just like to share a personal anecdote about how I became aware and interested really in healthcare policy. So my mother grew up in a small town in South Carolina, and she, at the time, Black adults were not permitted to deliver babies in hospitals because of the Jim Crow segregation laws. And so my mother was born in an old country house on my grandmother's farm. And as you can imagine, by not having access to prenatal care, not being able to deliver in babies, the infant mortality rate in that town was extremely high. And my family did not escape that. 3 of my grandmother's children died before they were 6 months old. And I'll never forget the first time in my 20s when I drove to that old country house and saw it. That is where it became crystal clear to me that access to quality healthcare is directly related to healthcare policy. So this notion of creating options for value-based care and addressing social determinants is absolutely critical, and that is one of the most pressing policy initiatives of our time.
If I could chime in there real quick, there's a really great Commonwealth Fund slide. You alluded to this, that everyone knows this, it's not a secret anymore, that US spends approaching 20% of GDP. During the pandemic, we got really dangerously close to 20%. It was like 19.5% of GDP on healthcare. Yet our outcomes look like we're on par with about the Czech Republic and Chile. Those are our peer countries from a life expectancy standpoint. And so this is well understood. But what is less well understood is this slide, and I have this visual of this Commonwealth Fund slide that shows the combined social care spending and healthcare spending among all of our peer countries. If you combine the two, we're actually not an outlier, we're right in the middle. The difference is proportion of spend. We spend about 2/3 of the combined spending on healthcare, about 1/3 on social care, where most of our peer countries are flipped. And so we could imagine in this lovely sort of Disney version of the story where federal policy would change to invest more on social care spending. I don't see that happening given the current politics of the day. But what we can imagine is a redistribution of healthcare spending in such a way that we spend it on social care because that's where the value happens. We reduce the total cost of care. We just by changing the incentives, like I was talking about earlier, it allows us to redistribute those funds in a way that has greater value to the total system and makes it sustainable for systems like ours to invest.
And I want to go to questions. If you have any questions, feel free to raise your hand. I'm going to ask one more, but we'll get a microphone over to you. Before we do, so what I hear you guys saying, which makes a ton of sense, is we need to refocus. We need to treat people as people rather than as patients. We need to think about their health before they walk through the hospital's doors. But at the same time, I also feel like I've been hearing this, like this was the same mantra I heard before Obamacare, right? I've been hearing this for years. What is the opportunity? Clearly, federal changes are even less likely going forward than they were in the past. So how do we attack this problem and get the systemic change? Is it about city governments, state governments, individuals?
It's people like us who visit with our congressmen and senators and educate them that they are going to be net better off with a value-based proposition. We have to teach them what's wrong with the fee-for-service system. But there's another message that I think we're failing to communicate adequately to our politicians. They talk about inequities in healthcare, and they think, what are we going to do about it? And they turn around and often would blame us. They'll say, you know, your clinics for the Medicaid patients aren't the same as your clinics for your commercial patients. You know, you're promoting, you're institutionalizing healthcare inequality. The reality is that those people who don't understand that when you so grossly underfund Medicaid, you institutionalize inequality. If you can't make those patients, if we can't receive what we need to just break even on them, what are we going to do?
Yeah.
We can't forever cross-subsidize. There has to come a time when even the most progressives realize that if they want equality, they have to pay for it. You can't institutionalize inequality like we have by sitting there in our state in Albany, underfunding Medicaid, and thinking that there won't be consequences.
Okay, so the first takeaway I'm hearing is everyone in this room needs to contact their congressman, contact their senator, and say this is something that there's a problem here, these are solutions that we will vote for. We'll donate dollars to candidates who care about this.
In a value-based proposition, you know, let's have an equality of what we pay.
Yeah. Yes, please. Let me say one thing, and if I misgender anyone, I totally apologize. I always say sir and ma'am, but I mean to call you, whoever you are. So you in the jacket.
Thank you. And if this is out of sequence, if you're on a roll about value-based, please don't stop. But I'd love it, Dr. Davis, if you could comment on what I understand is a pretty stretched provider system. Health systems all over the country right now are apparently between the costs of nursing that have gone way up, the shortage of people, supply chain, and basically a cost structure that is now vastly out of line maybe for short-term reasons, but for reality reasons with the reimbursement schedules. And my understanding is it's really at the breaking point in a lot of places. I don't hear national dialogue, and if I'm generally right, I'd love it if you would comment on that.
Welcome to discussions that I have at least 50% of the time today when I'm at work. What are we going to do about staffing shortages? What are we going to do about supply chain inflation? And we're not suddenly going to clone a bunch of nurses or, pulmonary techs. So there's a solution that is a little idiosyncratic to Mount Sinai, and then a solution that I think is more generalized. I'll start with the generalized solution. We have to rethink how we deliver care. We have to use lower licensed people at the highest level of their license. We have to form teams of providers that are a mix of different professions so that they can hand off the work to people of lower license who they supervise, because we're just not going to have enough people. And we're doing that. I mean, we're rethinking from the bedside right through to the ambulatory services. How do you remission people?
Hey, can I ask one question on that? When you say lower level, are you talking about mid-levels?
Physician assistants.
Nurse practitioner? Are you going physical therapists, pulmonary
Everybody.
techs?
Yes.
Okay.
Yes, everybody. Now, we're going to rethink how everybody does their work. But the second part of your question, you remind me. So here's what else we're doing. We have a good fortune that we run a nursing school. It's called the Phillips School of Nursing. What we've done is we are now, over the next year, going to double the size of that school, so that within a year or two, with the people that we're bringing in, nursing assistants and people who need 2 years instead of people who need 4 years, but even the 4-year program, we'll double the number of nurses that we turn out. We're also providing free tuition for those people who commit at least 2 years to stay in our system. So at the Mount Sinai Health System, because we have a feeding nursing school, we're going to be able to deal with the nursing shortage. What that speaks to is the deficiency across the country in nursing education. We need more nursing schools, and those that we have need to grow. When you ask them, why can't you take more nursing students, they say there aren't enough teachers here, or they'll say the facilities are too small. That has to be something that we address at a governmental level. So we can deal with it, but I think as a nationwide problem, we have to address the underfunding in nursing education.
Dr. Hankerson, Dr. Phillips.
Well, I was just going to add one more thing that I think Kent is alluding to. As much of the efforts as we're going to try to put in to make up, because there's a physician shortage as well, and I mean there's a shortage all the way through the entire labor force in healthcare. But I was in a talk earlier today about teachers going through the same process, where we're using a medical term, hemorrhaging teachers, right, in our system, but we're also hemorrhaging nurses and physicians, et cetera. And so it requires, I mean, of course, increasing the supply, but it does require fundamental change in the delivery model, as Ken is alluding to. The inhibitor to that, or the barrier to that, goes back to the incentives and financing, right? For example, a outpatient practice is primarily only reimbursed for a face-to-face visit, or now, since the pandemic, a televisit. It's the only thing that we get paid for. There are dozens of other interventions that would get you to the same or better outcome for the individual seeking care that don't require either of those two options, but they are not sustainable. We get zero reimbursement for anything else other than those two things. So if you're forcing all types of delivery into essentially two models of care, which all require some sort of physician intervention, so you have a limited supply of physicians, your only form of reimbursement is going through physicians or advanced practitioners, that's a misalignment, right? It's very difficult to innovate on delivery if you're only incentivized in really narrow-minded ways. And so it all feeds into each other. It's hard to, one of the advantages of a venture or private equity-backed group is that they are free to deliver and innovate like crazy without having to prove they can be sustainable or make any money, right? And we're not in that sphere. We literally serve everyone that walks through the doors and have to deliver to everyone. We are morally obligated to do so, but also legally, by the way, obligated to do so. we must innovate in order to do that, but that requires some support on the way we are funded to allow us to have a little more creativity in how we do that.
That makes a lot of sense. Dr. Hankerson, let me ask you, because psychiatry strikes me as one of those places where, when it comes to mental health services, we have a lot of folks who are unlicensed, unrecognized as providing mental health, whether they're a social worker, whether they're a minister, whether they're someone who plays that role in an apartment building. In addition to thinking about how we change the financing, is there an aspect of what Dr. Davis is saying that expands into our community in a way that people become medical providers who are not accustomed to thinking of as medical providers? And is that important?
That's critically important. So just to give some context, so my research focus is major depression. The economic burden of depression among US adults is $326 billion per year. So depression is a huge issue, right? That is often underdiagnosed and undertreated, especially in communities of color. And so I think that the notion of there's this empirical research about task shifting, where you can equip kind of lower licensed folks in the community. We're working with community health workers. Most of our community health workers are retired nurses, to Ken's point. They're retired social workers. So they have some healthcare experience. But they're retired or they're doing a second job, and now they are screening folks for depression in the community, providing brief counseling, and then serving as patient navigators to help get people connected to treatment.
Yeah.
And importantly, they're connecting them to social services that are really the drivers of these folks' depression.
That's really interesting.
And so this model has been, and Rob and I have been talking about some of the innovative work that he's doing with community health workers, and what's important is to try to create sustainable models that is a win for third-party payers, for patients, and for healthcare organizations.
Who else has a question? Yeah, over here? In the blue?
One of the popular problems that politicians have been talking about for the last few years is single-payer health care or Medicare for all. Do you think this is a good thing? Are you deathly afraid of it? What's going to happen to the private insurance companies, or is this all dependent upon the reimbursement that gets passed?
Rob, you want to start?
You should answer that first, or I don't get fired. I'm just kidding.
Look,
No, I'm just.
I just don't think it's a reality that we have to worry about in this country. So single-payer system is not going to happen in our lifetime. So I got to worry about the problems that I'm going to face in the next 2, 3, 4, 5 years. And I don't sit around and wash my hands about, I'm going to have a single-payer system. Oh my God, what am I going to do? When anybody brings it up, here's what I tell them. Just pay us our costs. You want to have a single-payer system? Fine with me. Just pay us cost. And that'll roll their eyes if they look at what our real costs are and they realize they can't afford it.
And I think Ken's absolutely right, all kidding aside. I mean, I think we talk about single-payer system or Medicare for all or fill in the blank. If you look at other countries, everyone wants to point to the Canadian system for its pros and cons. There are dozens of different versions of single-payer system across the globe with all different variations on the theme, all with their different strengths and weaknesses. And so maybe it's a solution, but to Ken's point, it's really, I don't think we care where the reimbursement comes from as long as we're reimbursed fairly to deliver the care that we need, right? I mean, I don't, in fact, there may be a lot of administrative savings, frankly, if there were one payer to deal with knowing how many times we have to go to court to just get the money that we're owed from the private payers today. Having said that, not to go too far on a tangent, but I said before, we have an obligation as a health system to literally take care of every single person that walks in the door. So whether or not it's important in this context, whether or not healthcare is a right constitutionally or not, given the context of the last week, is irrelevant, right? Because we are obligated to care for everyone. We have decided societally that it's not okay to let someone bleed on the street outside of the ER. We must see them and evaluate them and take care of them. So whether or not you think it is a right practically, I don't know of no other service. We all take great comfort that no matter where we are in America, something should happen to us regardless of our age, our gender, our documentation, anything. If we go to an ER, we have to be served and cared for. We don't protect education that way, food, water, transportation. Literally any other service is not protected to the level that healthcare is. That's a huge obligation. We just finance it in literally the dumbest way possible. And so when you say Medicare for all, well, maybe, right? If that means that we equal access all the way across and distribute funding in a more equitable manner that covers our costs, sure. But I think as a catchphrase, we just have to be careful what you mean by that. I do think that there is a fundamental need to rethink how we administer healthcare and finance healthcare across the country, given the burden that we put on health systems to try to deliver that care for everyone.
And it's probably only going to become more extreme, right? I think.
Absolutely.
There was a question back, yes, in the blue shirt here. If you don't mind, we'll run a microphone over to you.
This could be great. This is my wife.
Hi, I'm a practicing physician in Austin, Texas, and we're fee for service as far as you can see. Are there any working examples of value-based care at scale in the U.S.? And separately, how good a job are hospitals and physician groups doing at controlling the risk side of that equation, or is the money just not there?
So, I mean, I think the one that everyone points to at scale is Kaiser, of course. They've done it very successfully at scale with some pretty amazing outcomes on clinical care as a result. Is it perfect? No, but they do it. That's the one that everyone points to. There are smaller examples where you see large sections of care being delivered in a value-based model. So, famously, I think Intermountain, Geisinger, Advocate Aurora in Chicago, that are. Frankly, us. I mean, we have 500,000 lives under some form of value-based arrangement, by far the largest in the city that we manage in sort of a value-based model. But I think from a national scale, Kaiser is probably the one that has done it. In terms of the downside risk, so what the issue is here, if you think about these value-based programs, for not to get hyper-technical here, but everyone understands how insurance works, right? Premiums go into a pool. We pay for those widgets I mentioned earlier out of that pool, and if you overspend on the widgets, you exhaust the pool, well, that money has to come from somewhere. It either comes in premium increases or insurance, and there is insurance to cover those losses. And so your question is probably leading, how are prepared our systems to deal with that downside risk? I would say not very is the short answer, but I think increasingly becoming more savvy. Certainly we have had to do that, and a lot of evolution in the last couple of years for us as we've taken increasing downside risk on stop loss insurance and things like that. And but I think it is a lift for many systems. I don't think everyone's quite there yet. And it's even harder for smaller groups, not even the health systems, but primary care physicians, specialty physicians, and outpatient. Taking that level of risk on the downside is very challenging, which is why often you see private equity and venture money coming in to help subsidize some of that risk.
So she has a question.
Yes. Which one were you pointing at?
The one with the mask. That's my wife. She wants to say something. Otherwise, I'm in trouble.
Hi, Dr. Field. As you know, I work on innovation at Mount Sinai as a trustee. I've also been a Kaiser intern and resident. Now, you mentioned that you think it's not efficient to deliver health care the way it's currently reimbursed, with in-person visits and video visits. Let's just fantasize that you had philanthropic support for a pilot project. What mechanisms of health care delivery would you put into that project?
Oh, this is awesome. I love this question.
So by the way, we'll be taking names afterwards for who wants to provide the funds.
So at Mount Sinai, we've actually started many of these projects. I mean, Sidney's mentioned some work doing community health workers in churches. We've got projects using, for example, community health workers and clinical pharmacists to tackle the perinatal outcomes and maternal morbidity disparity that we have in the city. So what that model might look like, these are pharmacists that are not your dispensing pharmacists. These are pharmacists that have 2 years of postgraduate education that actually can write for medication, and they partner up with the physicians, which is the most limited resource as a physician. So what they do, along with the community health worker, is follow these women as soon as they enter into the system during the prenatal care, visit them at home, give them education, provide them support, identify when they may be at risk of gestational diabetes, preeclampsia, hypertension of pregnancy, those conditions that often drive the NICU stays and the fetal deaths and all those other things. And then when they identify those folks, pair them with a clinical pharmacist who is able actually to manage those conditions at home, over the telephone, write prescriptions, not having to come into the office. I mean, with simple technology, like no internet, no iPad, nothing fancy at all. So between the community health worker providing that social care support that Sidney mentioned earlier, which is a huge strength, and a clinical pharmacist, which is a growing labor force, actually, we're able to provide really amazingly high quality care. Now, we've just started on the maternity side in a pilot project, but we have plenty of experience in a similar model in a general hypertension population, where we found in our results of the roughly 1,000 people enrolled in the early part, we now have about 1,500 enrolled. 65%, I may have these numbers a little bit wrong, so forgive me, but it's something like 65% of those patients come from household incomes of $50,000 or less in New York City, which you imagine is not very much money. And over 70% of them are either African American or Latinx, which are disproportionately affected by undiagnosed hypertension. And their hospitalization rate compared to matched groups is, we have a 75% reduction in hospital admissions in that population using a model like this. So we think the impact on prenatal care could be huge, but we're starting small. So if there were philanthropic dollars, we could scale programs like this to prove sustainability, right? If we had enough scale to prove that this actually reduces total cost of care across a broad population, it becomes easy then to sort of think about the payers subsidizing these kinds of models with a different reimbursement method, if that helps.
So here, oh, sorry, Sidney, go ahead.
Yeah, I'd love to answer that question. So my dream pilot project would integrate care coordination, community engagement, health literacy, and connections to the hospital. So excellent clinical services. And it would be able to identify people at risk for serious health conditions across the lifespan. So one of my growing interests is in our kids and youth. We know about the rise in suicide and mental health challenges in our kids. I was fortunate to get funding from the American Foundation for Suicide Prevention to try to implement a program called Youth Connect, which really builds social connections, increases awareness about depression and suicide risk factors, and also provides mental health literacy for parents. And so I think figuring out how to engage kids early, as well as thinking about family-based models, would be critical. And then for our adults, building off of what Rob said in terms of linking people to community health workers and that model. And then certainly for older adults, you know, as baby boomers are getting older, certainly Dr. Davis can speak to Alzheimer's disease much more eloquently than I, but certainly wanting to identify people at risk for disease and getting them connected to care, I think would be critical. So that would be a dream pilot project, linking community engagement, literacy, and connection to services.
Let me make a point here, which my wife Bonnie knows about, but I think others ought to hear. Bonnie just asked the question. You know, the problem that I'm a neuroscientist, and when I listen to the questions of, well, why can't we deliver better care? Part of what I think about when we hear about depression is we really haven't had a breakthrough in depression psychopharmacology for nearly 60 years. We have a little bit of ketamine, but by and large, science of antipsychotics, antidepressants, anti-anxiety, hypnotics, it's 60 years old. Why is that the case, and why does it continue that way? And a point that my wife and I make, and she makes frequently, is for all the good the Affordable Care Act did, they put something in that was to the benefit of the drug companies that really has hindered further the development of brain drugs. And that is market exclusivity for large molecules, proteins, the kind of infusions that you get for 12 years, which means, you know, no matter when your patent life is, I got 12 more years to market this drug. In contrast, no matter how your patent is for a pill that you take, a simple oral pill that you take, it's 5 years. Now, those big molecules, they don't get into the brain. They don't get past the blood-brain barrier. So what happens to big pharma? They close down the neuroscience sections. They start to develop all these drugs that we're infusing at Mount Sinai for a lot of the diseases below the brain. But we're making no progress at all in the pharmacology of brain diseases.
That's really interesting.
And that's a major cost to the healthcare system. And as my friend Sidney just pointed out, so many untreated people.
Yeah.
And we just don't have the tools, the better pharmacology to take care of them.
Okay, so what I've heard so far, the mandate is, number one, talk about this to elected leaders, talk about this to our neighbors. Number two, if we have a spare couple $1 million, definitely give you guys a call. Number three, and I want to ask something about our personal responsibility with how we use medical services, because I imagine everyone in this room has a pretty good healthcare plan. I belong to an HMO in California, not Kaiser. And I will say, I run that thing like crazy. I wanted to get Victoza because it helped me lose weight. I have no history of diabetes. And I just browbeated the insurance company for 3 months, and then they started paying for Victoza, right? I am an abuser of our current system to my own benefit. Should I feel bad? Am I part of the problem?
Well, yes. I mean, we're all part of the problem. And that's that, not to quote this person, but healthcare is actually complicated. That was correct. But we all bear some amount of responsibility, right? The payers certainly do, government certainly does, systems certainly do, and all of it is around incentives. But also consumers do as well. New York in particular is a great example. So an average Medicare beneficiary total cost of care where I was in North Carolina was just shy of $8,000 a year. In New York, it's about $14,000 or $15,000 a year. Not because they're almost twice as sick in New York. It's just the patterns of utilization and how people seek care are different in New York than they were in North Carolina. People saw me, I'm a primary care physician, so in North Carolina they would see their primary care physician 3 to 4 times as much as a specialist. In New York, the ratio is 0.4, 0.7. It's just, there are definitely behaviors on the consumer side that drive a pattern of utilization that can be really costly. We want what we want.
Yeah.
And Lord knows, as soon as our deductible is met, and everyone's getting that MRI they always wanted, right? Because they don't have to pay any out of pocket.
All I got to do is make a couple of phone calls.
We're still consumers in the end, right? And we want what we want. And so, yeah, there's a little bit of responsibility.
Let me ask the doctor side of that. One of my colleagues at the New Yorker, Atul Gawande, a number of years ago, wrote a piece about 2 towns in Texas.
Yep.
One of which had the highest Medicare costs in the nation, and the other had some of the lowest Medicare costs. Yep. And a lot of it in his diagnosis was physicians in one town wanted to be wealthy. They were very focused, and I'm not going to accuse any of you or your colleagues of wanting to be wealthy, but there is a focus on specialization. There is a focus on more prestigious, higher paying specialties, which does mean we have fewer family docs or that they're more scarce. Are doctors part of the problem? Not just doctors, but medical providers in general. What do you think?
Look,
Yes.
You take the average medical school graduate.
Yeah.
He's got a huge debt. He looks at that debt and he says, gee, I really would like to be a primary care physician, but how am I going to ever pay all this debt? And then he sees down this, during the residency, during his rotations, he knows that those cardiothoracic surgeons, they're making a fortune. And those orthopedic surgeons, they're making a fortune.
And they get to schedule everything.
So what do they do? I mean, we now have an excess of specialists and a deficiency in primary care doctors. It's a triangle, backwards. We would like to have more primary care doctors and fewer specialists, but that's not what we have. And until we change those incentives, that's what we're going to have.
Psychiatrists the same way.
Yeah. No, medicine is funded by procedures. And psychiatrists, we don't do procedures. So it's a huge issue.
Okay, so we have just a minute and a half left. And if anyone does have any questions, I invite you to come up, I'm sure. Okay, go ahead. Right here.
This is more of a processing question for me. I'm thinking about this blue skies conversation, not outside, no, about what it would look like to be able to put together a model that really does deliver care. And I'm thinking particularly about the prenatal structures that you both had shared, both personally and professionally. And credit to the young woman who I worked with over the past year, but I'm wondering about the role of perhaps doulas or midwives in those sort of spaces, and how trainings, programs, initiatives maybe could come about to fill those gaps. I'm just wondering thoughts on that.
Yeah, I think that really spoke to Ken's point about really training up a cadre of different professionals. When my wife and I had our 2 girls, we certainly utilized the services of a doula in addition to our OBGYN, and we found it critically, valuable. So I think it's critical to kind of build up really an army, a cohort of various healthcare providers at different levels.
We're almost at, go ahead, sorry.
Just quickly, I mean, I think it goes back to the incentives problem, though. Like, if you have means, you can invest in that. How do we get those same interventions that are proven to work across all populations? It kind of goes back to there aren't incentives to do that today, and the individuals often can't afford to do that. So it's tricky.
So let me just ask one last thing, just a quick wrap up. What do you hope that folks in this room will do tomorrow, will do next week, next month, based on hearing this, that you think will move the needle?
I mean, for me, it's, understand the inequality in payment, and that your legislators are underfunding Medicaid grossly, and as a consequence are institutionalizing inequality in healthcare.
Yeah.
And for me, in addition to the inequalities in payment, it's really developing models that address social determinants of health. We know that education, food access, housing access really drives healthcare challenges. And so it's really thinking about how can we develop models to fund that in a sustainable way.
Dr. Fields, do you have any?
Yeah, I mean, it's hard to add to those. I mean, certainly investing in social determinants. Maybe the one thing I would say that's different, because I agree with both of those comments, is to just not be afraid in your voting and your advocacy for radical change from a federal level, even in terms of how healthcare is reimbursed and funded, whether it's Medicare for all or, but in order to achieve Ken's vision of equitable payment, I think it does require a wholesale overhaul of how we think about that nationally, and to not be afraid of it. Actually, CMS actually does a really good job, even though it's maligned in lots of ways. Their overhead expenses are low. They deliver care. They're the largest health insurer in the world. It functions reasonably well. Anyone in my family, my brother has ALS. When he got sick, he was asking me, should I choose a Medicare Advantage plan or traditional Medicare? I was like, traditional Medicare all day long. You know why? Because there isn't prior authorization. There aren't these other barriers to care. It's actually much better delivery of care in traditional Medicare, in my opinion. I know there's probably some Medicare Advantage folks, but that's what I told him. It's just don't. I guess I would ask just to not be afraid of this sort of level of transformation.
Well, gentlemen, thank you so much for your time. Thank you to all of you for your questions and your comments, and let's make the world healthier. Thanks.